Good morning. Continuing with our conferences, we have the privilege of having Dr. Stephen Shapiro with us with the conference of evaluation of the validity of the tool for connectorous spectrum disorders for determining their type and severity. Dr. Shapiro is director of the Connectorous Center of Excellence, the Division of Neurology and the Department of Pediatrics of the Children's Mercy Hospital in Kansas City, and he is also a professor of pediatrics at the University of Missouri, Kansas City School of Medicine. Dr. Shapiro, it is an honor for us to have you with us this day.
Thank you very much. Hi, this is Dr. Steve Shapiro from Kansas City. It is a great honor to be here with all of you and all my friends from Mexico. I'm going to talk to you on the evaluation of the validity of the Connectorous Spectrum Disorders Toolkit to determine its type and severity. And you could see a picture of our Children's Mercy Hospital complex with most of the buildings. There are several more since this picture was taken. So first of all, let me start, and I apologize for not being able to speak in Spanish, but you don't want to hear me try. What's in a name? Connectorous comes from the Greek icterus, yellow, and kern, meaning kernel or deep nuclei of the brain. Bilirubin encephalopathy is a term, as neurologists, we like to use, either acute, which is the acute symptoms in the newborn, and chronic. We don't like the term chronic anymore, as my colleague and friend Dr. Lipischon pointed out. Bilirubin encephalopathy later on is not chronic, it's not ongoing, but it is a static encephalopathy. So we're just calling it bilirubin encephalopathy or connectorous. And once I get my arrow here, bind is a term that's been used a lot, bilirubin-induced neurological disorders or dysfunction. The problem is it's used inconsistently in the literature to refer to both subtle connectorous and all kinds of connectorous, from subtle or mild to severe. And one can't do outcomes research without clear definitions of outcomes, so terms must be clearly defined. I can't see myself or the screen, but could you tell me, can you all hear me clearly? And am I speaking too slow or too fast? Could I get some feedback from the whoever is monitoring this? I'll go on. So we prefer the term connectorous spectrum disorder to refer to the spectrum from mild or subtle to severe encephalopathy. And because the terminology is consistent, it supports studies of the natural history of this disorder and developing evidence-based prevention, neuroprotection, and treatments. The pathology of connectorous is selective yellow staining in the basal ganglia, especially the globus pallidus, also subthalamic nucleus. Specific staining in the brainstem, including the auditory brainstem nuclei, cochlear nucleus, inferior colliculus, superior olivary complex, the oculomotor nuclei, especially nuclei controlling upward gaze, vestibular nuclei, cerebellum, especially Purkinje cells, and hippocampus. In a different area, the CA2 sector that's affected by hypoxia ischemia. There are classic correlations of the pathology with the clinical symptoms. The movement disorder of specifically the dystonia and athetosis is largely from effects on the globus pallidus and subthalamic nucleus. The auditory findings, including deafness, hearing loss, and especially auditory neuropathy spectrum disorder, which I'll talk about in a minute. The brainstem comes from the brainstem nuclei, and right here are the cochlear nuclei that you could see, stained and dying in this section. Here's the brainstem oculomotor nuclei that cause this setting sun sign that you see in newborns. who have difficulties with upward gaze. There can be staining of the deciduous or baby teeth. It's hard to see right here, of the enamel, although it's just the baby ones, and the permanent ones should be okay. And there are also findings in the cerebellum, vestibular nuclei, and the hippocampus. Here's a baby who's 3 months of age, where you could see that sunsetting sign that you can see in newborns with severe kernicterus. Dr. Tina Slusher and Dr. Joshua Owa from Nigeria, Michael Painter from Pittsburgh, and I described the so-called kernicteric face in newborns like this. It's a scared look with the eyes going down. It's a combination of it setting sun sign, paresis of upward gaze, eyelid retraction, which is a Collier sign that has to do with dorsal midbrain lesions, and facial dystonia. Older children, one sees athetosis, so-called athetoid CP, or dystonia, dystonic CP. You can have hypotonia and hypertonia. It's not spastic. In fact, the hypertonia is not velocity sensitive as in spasticity, unless there's a concurrent, another injury. Where does kernicterus damage movement and motor control? Well, you can see this on an MRI. Early on, the T1 weighted images are hyper intense, and you could see the globus pallidus here bilaterally in this child who was, I think, 8 days old. And this is on a sagittal view where you could see both the globus pallidus and the subthalamic nucleus. And then later, probably at about 6 months of age, maybe 6 to 18 months of age, or 6 months to 2 years approximately, you can see these same lesions that are now on T2 hyperintensity bright here and here. And you can even see, here's a 1.5 Tesla MRI where you could see both the globus pallidus interna and externa. So in most of these children with kernicterus, you can see MRI findings. Where does it damage the auditory system? It does not damage the ear or the inner ear hair cells. It does damage the brainstem auditory nuclei. It may damage the auditory nerve nuclei, which is in the spiral ganglion. You can assess these physiologically with brainstem auditory evoked potentials, and you could assess wave 1, 3, and 5. You can assess cochlear microphonics. You could assess the hair cells, the inner and outer ear hair cells in the ear, which are not affected, but are in other types of hearing loss. And then cortically and subcortically, above the level of the midbrain or inferior colliculus, there's no damage in the auditory system or cortically. A characteristic feature of hyperbilirubinemia-induced brain damage is auditory neuropathy spectrum disorder, which is absent or very abnormal BAEPs, also called ABRs, auditory brainstem responses, with normal cochlear microphonic responses, which can be easily done during a routine BAEP test. And this implies the inner ear is normal, but the auditory brainstem nuclei and or the nerve are abnormal. And it's distinct from sensory hearing loss, but with damage from bilirubin neurotoxicity, the two may be concurrent. So back about 10 or 15 years ago, we talked about some new definitions of kernicterus, and I proposed classifying them by location, either classic or auditory predominant or motor predominant. Now, these aren't the only symptoms of kernicterus, but they're the ones that are most causing of disability. So classic kernicterus is the classic triad or tetrad of deafness and or an auditory neuropathy and motor symptoms such as athetosis and dystonia. Auditory kernicterus is predominantly this auditory neuropathy spectrum disorder with minimal motor symptoms, and motor is predominantly motor with minimal auditory symptoms. So in a paper from 2010, I classified kernicterus by its severity and type of sequelae into auditory and motor, and basically described mild, moderate, and severe, and what distinguishes them two, and tried to put some consistency on defining this symptom. And sorry, my screen is just jumping all by itself. Here's a child with rather severe dystonic cerebral palsy, which is severe motor kernicterus. So one of the issues that comes to me as a neurologist is children who are sent to me saying, is neonatal hyperbilirubinemia the cause of a neurologic or neurodevelopmental disorder? This is a very frequent question, and I want to go through first how I view this, how I think about it when I see children in the clinic or review their charts and their lab data. And then this is going to give the reasoning behind coming up with this toolkit. The first thing I look for when I see a child, I want to know the history. Is there an excessively high bilirubin? At minimum, I'd like the bilirubin to be at a level where neonatologists and pediatricians would give phototherapy to reduce the bilirubin so it doesn't go higher. Stronger evidence of a high bilirubin would be a level that would be high enough to recommend a double volume exchange transfusion, a drastic treatment. And one would consider other risk factors such as its duration, whether the child is premature, sick, acidotic with a low pH, or has RHD disease, because all those factors make any blood level of total bilirubin, total unconjugated bilirubin, more concerning. And in fact, all right, I will go back. So, and then one looks at neurological symptoms at the time the bilirubin is high. What is the tone? Is it abnormal? Is there a high-pitched cry? Is there posturing, opisthotonous? Or is there abnormal eye movements, including sun-setting sign? The second thing I look for to answer this question is the exam at the time I see the child. Is there abnormal tone, or are there abnormal movements? Is there dystonia, athetosis, coordination? Is there a hearing impairment or a difficulty understanding speech in a noisy environment, on the telephone, or with sound localization? Those are signs that there may not be a hearing loss, but there could be this auditory processing disorder called auditory neuropathy spectrum disorder. And are there abnormal eye movements, especially lack of upward gaze, which may resolve, but all sorts of both horizontal and vertical eye movements may be abnormal. And is there, or was there, a history of dental enamel dysplasia, staining or flaking of the baby teeth? That's inconsistent. They may not have it. And if you have that, that could be from other things as well. The next thing is laboratory. The auditory brainstem response, or brainstem auditory evoked potential, can give you specific findings of this auditory neuropathy spectrum disorder, which is uncommon in the general population. It's about 50% of cases are from hyperbilirubinemia. The rest are from rare or not so rare genetic causes. But this is an uncommon issue. So having this increases the likelihood that there was bilirubin neurotoxicity. And then MRI findings are quite specific, almost pathognomonic, with hyperintensity in the globus pallidus and maybe the subthalamic nucleus, and really no other lesions, nowhere else in the basal ganglia, no neocortical lesions, perhaps sometimes a little bit other areas like hippocampus, but it's it's this without areas that might be affected with hypoxia, ischemia, or other thing that are quite specific. And also absent other etiologies, but you can have them concurrently at the same time. And just one note that of these high bilirubin levels, these are levels that the American Academy of Pediatric Guidelines, which have been accepted worldwide, I believe in Mexico, these are levels where they would recommend treatment. So just roughly, I would like, if somebody is going to have a neurologic syndrome from bilirubin, to have some evidence that there is a high level of bilirubin, or if not, there has to be some other explanation, such as a dysplasia or acidosis, etc. So moving on, why a toolkit? Well, there's no definite test for the diagnosis of a kernicterus spectrum disorder. If you have a toolkit or criteria, that enables research and a registry on this rare disease to understand better its natural course, symptoms, neurodevelopment, the effect of therapies and treatments, and to ensure your any subjects you enroll in a registry have some validation of their inclusion criteria. So initially, the first toolkit we made was in a grant to a U.S. funding organization, PCORI, in 2013. And just to show you, it was taking the things that I just described to you: bilirubin scores, newborn risk factors, exam, follow-up exams, dental, auditory, and MRI, and making some numbers and all these examples of how you code things, and then getting a score here with a maximum of 13, which would be highly predictive of kernicterus, and 0 would not. And then we also had a second part of the toolkit which told the type and severity. So I classified things as auditory or motor symptoms, mild, moderate, severe, with some definitions of those. So let me just show you. So this is the latest iteration of the toolkit, which was published by Dr. Lippischon, Reardon, John Watchko, and myself in 2017. And there's the reference. And this is basically just the things I was talking about, these scores for all these things that I would use to evaluate somebody in the clinic. And then severity of auditory and motor symptoms, and then classification as to auditory and motor on a scale of none to mild, moderate, and severe. So let me just take you through very quickly. If I were going to score this, then one would just go and to each of these things give a score of 0 to 1 or 0 to 2, and add up the total score and compare it to interpretation here. This is really designed to send to parents, to send to referring providers, so that they could have some sense of how likely it was their child had a neurologic problem due to bilirubin neurotoxicity, and see if that could be helpful. So just for example, you could see this would be one that would score as probable, this would be possible, this would be not kernicterus, so hyperbilirubinemia with nothing else. And since 60 to 80% of babies have hyperbilirubinemia in the neonatal period, many children who have a neurological problem that hasn't otherwise been diagnosed will wonder if their child has it from that high bilirubin. This helps to say most of them are not. So if you have this one here, I won't go into this too much, but if you go to this chart here, you could say no auditory symptoms, severe motor, that would classify as severe motor kernicterus, mild auditory, moderate motor would come to moderate motor predominant kernicterus, and severe auditory, severe motor would be severe classical kernicterus. So that's sort of the scheme. So next question is, how do we validate this as a toolkit? Well, we have IRB approval to ask families to participate in a research study. And if they, as part of the intake, they can participate and fill out this toolkit before they're seen. But recruitment has been slow for a number of reasons, in part due to COVID-19. So we decided first to perform a retrospective study comparing the kernicterus spectrum disorder toolkit to the results of comprehensive evaluations we had done in our clinic in Kansas City. We identified 55 children who had been evaluated in the clinic. We wrote a poster that was presented at the 49th Annual Child Neurology Society meeting and 16th International Child Neurology Congress in October of 2020, last week, in San Diego, California, virtually. And it was presented by a medical student who's in her final year at University of Missouri, Kansas City, Vijaya Dasari, myself, Dr. Ye, PhD statistician, and my colleague in child neurology at Children's Mercy, Dr. Rose Gelano Morel, who is a pediatric neurologist specializing in movement disorders and also MRI imaging. So I'm going to take you through this in a few slides and hopefully make it understandable for the rest of the talk. So first of all, I just said that families, with an arrow here, families of children with undiagnosed neurodevelopmental disorders often question kernicterus as a possible diagnosis. So we developed this questionnaire to predict the likelihood of a kernicterus spectrum disorder. And by that, I'm talking about the whole spectrum of kernicterus disorders I just described. And so we compared the accuracy of this toolkit to the clinical diagnoses we made in our Children's Mercy Hospital Kernicterus Center of Excellence. The primary objective was to determine the accuracy by comparing the toolkit to the gold standard, full evaluation, and secondarily to learn which risk factors on the toolkit most strongly predicted kernicterus. So here's the methods. We reviewed 55 patients, but 37 of them met inclusion criteria, which means they were of the age less than 18. They were evaluated at our center between 2011 and 2019 and had the necessary chart information. Of those 37, 29 were clinically diagnosed as having kernicterus with a kernicterus spectrum disorder. 8 were diagnosed as not having kernicterus. So one of us, the medical student, completely reviewed the chart retrospectively for each patient and filled out this kernicterus toolkit, and then compared that to the gold standard of what was the diagnosis. And we then looked at sensitivity and specificity by various methods. So here are the results. Yes. Yes, sir. Did somebody have a comment or question? Okay, I'll continue. The results are that there were 14 patients who the toolkit said had definite kernicterus, and 14 of 15 who were probable, who all were clinically diagnosed with kernicterus. So 100% of the definites by the toolkit and 93% of the probables were correct. If the toolkit said possible, one was kernicterus, one was not, 50%. And if it said not kernicterus, all of them said not kernicterus, so that was 100% correct. So the total for all groups was 95% correct. It was basically positive predictive value and sensitivity of 96.6%, negative predictive value of 87.5%. And the statistician did some other analyses for sensitivity and specificity, and basically concluded that only 3 of these factors had specificity greater than 75, which is auditory neuropathy spectrum disorder, dystonia in the last neurological exam, or the specific MRI results that we were looking for here. But some of these had an extremely large standard of error of the mean. So conclusions, we met our primary objective of looking at the accuracy in this ideal situation of having the chart, reviewing it, the information obtained by experts, and then comparing that to their diagnoses, and finding that these 3 things were most predictive. The limitations of the study, where it was retrospective by chart review, the forms were not filled out in advance by parents or patients or referring providers. There's a potential for bias. The chart reviewer, the reviewer was not blinded to the diagnosis. There was a small sample size with unequal case and control groups, especially a small number of patients without kernicterus might have overestimated statistical significance. And the information in the chart was gathered by us pediatric neurology, bilirubin, kernicterus experts, and may not represent what the families or providers would provide. And some tests might not be available, bears or MRIs, or properly interpreted. So my final conclusion is it's a promising tool. It studies that under ideal circumstances it could work, and we're carrying out prospective studies and evaluating these filled out by families and referring providers prior to be seen in our clinic to further validate it. Future questions that a toolkit might answer would be having a validated kernicterus registry that you could reliably predict the risk of kernicterus spectrum disorders after excessive neonatal hyperbilirubinemia and acute bilirubin encephalopathy. How to design trials of potential neuroprotective strategies in neonates. Cochlear implants, which are used with success for the kernicteric auditory neuropathy spectrum disorder and deafness, how to predict whether this condition will improve or spontaneously or not, because it does in a minority. And how to establish evidence-based treatments, including specific therapies, medications, brain-computer interfaces for communications for the severe ones, deep brain stimulators, and where to put them for the severe dystonics, and neurorestorative treatments, including neural progenitor cells and stem cells to actually treat the underlying conditions. So I would like to thank you all so very much for inviting me. Hope to see you in Mexico soon. Here's where we were in Mexico in August of 2017 at Hospital Infantil de Mexico, Federico Gomez, and out for lunch at that time. And we had a great visit, and we hope to have more collaborations. In my talk, I have references. And the final thing is some links for parents, because I've seen a number of patients from Mexico and Spanish-speaking Latin American countries. There is a parent site here, and if you go to this PIC site, you can get into a group that has a Spanish language Facebook page. Here's our website at Children's Mercy and my email. If you have patients with this, please feel to share these links and information. Thank you.
Thank you, Dr. Shapiro, for your splendid and very rich conference. It is truly an honor to learn from somebody like you, who is the utmost expert in this field. Doctor, we do have a few questions that part of our audience would like to ask. The first
Excellent.
first question is the toolkit applicable to Mexican children?
Right now it's in English, but we certainly have qualified people who can translate it into Spanish. And we could ask my colleague, Dr. Quesada, who's going to be speaking tomorrow or the next day or this afternoon to you. and also Dr. Cowden, who's come with us to Mexico. We could ask Google Translate, but I'm told that that's not a good way.
Excellent, which would be an opportunity for future validations.
Yes.
Excellent. Another question, Doctor, is at what stage do you recommend performing an MRI on the patients? Is there any specific age and any specific age for follow-up with an MRI study?
So MRIs are, if they're abnormal, initially they're abnormal with a T2 weighted image probably for several weeks. Not sure how long, but 2 or 3 or 4 weeks probably, yes, and probably after about 5 or 6 weeks, I would think it may start to fade, and you might not see it on T1, and then you also might not see it on T2. And later on, sometime in the first year of life, T2 weighted images become abnormal. Now, there is a study from Japan that came out recently that looked retrospectively, and they felt the optimal age for seeing the T2 abnormalities were between 6 months and 18 months. So I would say between 6 and 18 or maybe 24 months, you should be able to see an abnormality if it's going to be there on T2 weighted hyperintensity of the globus pallidus, specifically also subthalamic nucleus. And then sometimes it fades, and later on you may not see anything, or it may be there. But you can make a diagnosis of kernicterus with a normal MRI, but most of the severe ones, the large percentage of them have abnormal MRIs. Excellent.
Another question that we have, Doctor, is the neurological damage always directly proportional to the bilirubin levels?
That's a difficult question, because what we are measuring is the bilirubin in the blood, where it's bound to albumin and the brain is protected. Now, other things we've done for another talk would be measuring the free unbound bilirubin, which was what can easily pass into tissue, including brain. There's no blood-brain barrier to free unbound bilirubin. So the height of the bilirubin is important. The ability of the baby to bind it in the blood is important. Other risk factors such as pH, displacers, and duration is important. So you could have a large amount of bilirubin that goes through into the brain briefly, and then you could have a small, another child with just enough to get into the brain, but over a long period of time. So it's very difficult to predict. One of the ways I predict is what the level was and how symptomatic the baby was as a neonate. So if there's neonatal symptoms, that's an indication there's toxicity. Brainstem auditory evoked potentials are very sensitive to neurological dysfunction at that time too. But most of the time it's pretty hard to say. That's why we like the idea of measuring free or unbound unconjugated bilirubin.
Thank you, Doctor. Another question that we have is, in patients with hyperbilirubinemic encephalopathy, what are the most common epilepsies you have observed in your center?
Most common are none. Most commonly what they do is they have, if they're very sick as a newborn, they have seizures, they have abnormal neonatal EEGs. They're usually treated and they usually resolve by 3 months of age. This isn't affecting neocortical. It's affecting hippocampus and CA2 and not 1 and 3. Right. So normally they resolve, but after following them from years, it could be the incidence of seizures in these children is a little bit higher than average. So instead of 0.5%, it may be somewhere, higher, and that could be from the bilirubin, and there is some it could be from concurrent conditions and being very sick.
Okay. Another question that we have, Doctor, is do you or have you been using CBD with any of your patients?
I have not, but some of my patients have been using them. And I have heard anecdotal reports that some feel it's very helpful. And I think it makes sense. And I would love to be able to do it, you know. When people tell me this, I don't know. If I had a registry and we could ask parents what they think, that would be good. But if the registry was validated so that we knew that everybody who said they had kernicterus was likely to have it, and that's not always the case, then I think we would do it. But then we really need some trials of that, because I think that has potential, maybe just for its relaxation effects on dystonia and athetosis, chorea.
Okay, and the last question we have, Dr. Shapiro, is what would be the most common alterations in neurodevelopment in patients with a silent clinical event?
A silent, you mean with subtle bilirubin encephalopathy, subtle kernicterus. The things I would look for would be auditory processing problems, such as delays in speech or reading, which could be because they're not hearing all the sounds of language and getting that because sounds are distorted. They might have normal hearing, but they're distorted. And there also may be some subtle motor problems, some excessive involuntary movements, or a little bit of dystonia that may be subtle. That's the things that I would generally look for. So thank you so much.
Dr. Shapiro, we thank you deeply for enriching us with your experience, with your knowledge, and we look forward to continue to learn from you and your colleagues. So once again, on behalf of the Children's Hospital of Mexico and the Medical Association of the Children's Hospital of Mexico, we do thank you.
And I thank you. And on my interactions and visits there, I have learned so much from you and your people at your hospital.
You will always be welcome here, sir.
Thank you.